Okay, thank you. And thank you for the very nice invitation. I really appreciate it that I was originally from Taiwan, so Singapore isn't so far away from my home. And this is nice to think to come back to this subtropical weather. And today I would like to talk to you more about our industrial perspective on how we think that the interpretable AI ML can be applied to find real-world evidence to help with the personalized healthcare in a way that it can combine behavior science into this AI framework. Yeah, and just a little bit about our research center. We actually have 3,000 researchers, most of them PhDs, in our research center across the world. We have 10 different labs, from the one in Yorktown Heights, which is the one I had, hosted about 1,500 people. And we also have the Haifa lab, the Tokyo lab, the China lab. We also used to have a Singaporean collaboratory here, and also in Zurich, Germany, Ireland, and South Africa and Kenya. So in my job, I am research staff member, and although we do a lot of research work, but sometimes we also have client-facing project where we have to work with our Watson Health product lines offering managers to know that how do we further customize our solution for our clients, right? So a lot of our thinking are then get driven by the feedback from our client base, and then we use those to understand a little bit more that in the practical setting, how to translate our mathematical thinking into real-world problems, and then embed the actionable insights back into the clinical flow or the personalized wellness management flow. And in that role that I started to understand a little bit more about this healthcare industry. And I found something very interesting and puzzling me a lot of times is that the health determinants that make us healthy, and if you compare those with the amount of money we spend on those, on the healthcare system to help people to get healthy, there is a disproportional and structural gap here that seems to be very, very obvious to me, but seems to be forgotten sometimes in our own healthcare system, especially in the United States, where we spend yearly 20% of GDP on healthcare. Actually, 88% of those the $14 trillion each year from our 20% of GDP go to medical service, while only 10% of the health determinant actually resides in the clinical factors, while there are 70% outside the hospital that capture the health behaviors and environmental factors that count more of those health determinants. We only spend about 4%, or if you count the other into 12% or most, to address those health determinants. So really, we need to have a way to start looking into how do we integrate care in order to help us to address all these different health determinants beyond the clinical visits, right? And Singapore as a country certainly has already started to be looking into this, and same as US. And the proposed solutions are often that we need better integrated care that can help us to connect hospital to home with some care coordinators. So this is what we call care management. And that's why today I want to focus a little bit more on care management and try to lead you to think more down that path, that how do we further bridge that gap between hospital and home using some of the methods that I believe this community are already developing. And really, if you look into this, then the key is that we need to start connecting all the different dots in the healthcare industry outside the hospital and make it interpretable, make the health professional being able to use the insight driven from all these dispersed data sources and aggregate the information together and find that meaningful interpretation of health behaviors in order to drive the change. And this is what humans are good at. Humans can observe what's going on in in another person by understanding the value, by understanding the morals, by using the common sense to interpret what's going on. While technology, on the other hand, is good at looking at these dispersed data sources I just talked about. As they are so dispersed, sometimes humans can help to really notice the pattern across all these different data sources in order to make sense. Right. So that's why augmented intelligence, from our point of view, is most important and most needed in this area when we are looking at so many different data sources and with so much noise and so sparse and with so many possible breakpoints. So our vision here is really that we want to enable health professionals to start being able to look into health behavior a little bit closer with technologies, with augmented intelligence. Just imagine that 100 years ago, without the stethoscope, the doctors cannot even hear the heartbeat. But now the doctors have the tools to look into this more carefully and understand the heartbeat patterns. This can be applied to understand behaviors as well. But in order to do this, we need data. And we need to start train our system just like now computer can recognize human actions from the computational vision and image data with almost 99% accuracy. We need to start using the data we can find to start train our AI ML to understand how to interpret health behaviors. But this is certainly still very new and very young field to healthcare industry as a whole, as we know that we can have to study things that one at a time. So right now in our new Center for Computational Health Center in Yorktown Heights, New York, we have started a new group called Computational Health and Decision Science, where then we started to examine these different data sources one at a time to see how much more health behaviors can we use those data to start interpret and help us to start getting more actionable insights out of those data that we can possibly find about a person. And so some of this has started from the medical claim that's originally residing in the hospitals. And we have many works before that. I can give you a long list that has studied that area. But our new group is trying to add some more value on top of our understanding of medical claim data by incorporating, for example, care management practice data, for example, mHealth data, in order to help us to enrich our understanding of a human for personal life. Yeah. Yeah. Oh, yeah. So medical claim data are those that were originally in the hospital, right? So those are EHR, and those can be insurance claims that tells you that when a person has really fill their prescription for medication, or it can be that the person has gone to some acute care facilities and needed some help, right? So, and then care management data is more those that connecting hospital to home. For example, say that one person that got discharged from the hospital, then in that, the person, as we described earlier, that in US and Singapore, there are more and more care programs that have been implemented for integrated care, meaning that they are now implementing the care programs by having the care managers to call those patients at home from using the third-party vendors usually to provide care management services. So these are the people who are not originally in the provider space, but they can help to further help the patient to get the kind of need they need at home and to be more familiar with the disease treatment regimens they are being prescribed. Right now, it's not. And it's often not even reimbursed, right? So we're just talking about US and Singapore just started to reimburse some of this. So some of this just started getting into the electronic record, but not all of them. Yeah. Yeah. Yeah, so sometimes that they use different communication channel to communicate with the patients, right? So right now, the kind of care management data we use are actually more traditional by calling. So care managers, after a person has been discharged from hospital, call them at home to start screening them and understand what kind of barriers they have, what kind of preferences they have in terms of intervention. But then there are providers who are implementing this extension from hospital to home through social media channel as well. Right. So that's why we're including some of these different communication channels in here. Right. But today I will focus more on the calls. But we are starting some new project with the New Jersey Direct Primary Care Facility where they use all the different channels, including text, including the mobile app, including the calls, and of course some of the clinical visits together to implement this. So different providers have different ways to do this. And here we are just starting to look into this area to see how we can make sense of those data that are previously being collected but not being looked at. Okay. Yeah. So then we got inspired by precision medicine, right? So as many if you're familiar with precision medicine, oftentimes it's about how did you identify biomarkers so you can design the targeting treatment accordingly. If not at individual level, then at least at the subgroup level. And then for us, then the analogy here is then can we try to find similar people behaving behaviorally similar, and can we find what we call behavioral phenotypes from those people in order to help us to understand what drives the difference in terms of their response rate to the intervention and drive the difference in terms of the engagement strategies that the care manager needs in order to engage that particular person better. Right. Yeah. And if we are able to do this, then we will first be able to provide some automatic measurement of behavior engagement level, which is previously as being indicated as very important for healthcare quality, but no one really have a way to measure it well other than doing survey. And also, if we are able to understand how people behave differently to the different interventions, then we know when and how to engage and to intervene for a particular person better. And this is what we call behavioral triage units, where if you understand the behavioral phenotype enough, then you can start using your understanding of their behavior differences to try to triage them to different behavior interventions. Right, and then we can start doing the personalized care planning, initially probably just by knowing that whether a person prefer coaching versus education, and then going forward, then when we have the mHealth data coming in, then we can start doing more refined planning, such as stage-based goal planning. So today I will going to give 2 case studies to illustrate the first 2 steps of this care planning process. Right. So the first one I want to mention is the one that we use the provider data we have access to study the behavior response difference. Right. So the motivation of this, as I described you earlier, that in the care management flow, sometimes we often see a patient as not just a patient. When it goes through the care management process, right now, at best, the care manager, what the care manager has when they are trying to call that person is a book full of the rules that they can possibly follow when trying to provide a patient assistance at home. So they will ask the patient questions, and then they will, based on the question, and to select the intervention to be given to this particular patient to attend their particular health goal. Right, but oftentimes what we see is that it's kind of one-size-fits-all approach doesn't work. Patients who had different priorities at home have different preferences to different types of interventions. And right now, there is no better way to help the care manager to have some indicators in terms of the patient engagement level and in terms of how patients respond to different interventions differently. And National Academy of Medicine actually has reviewed the 14 different care delivery models out there across 6 different clinical segments and have found out the most important successful care model, the attribute to the care model is targeting and planning, right? So this requires knowing who is more likely to be benefit from what interventions, and this has to be based on evidence. But right now, as we know that there is no one else looking into this domain to try to provide that kind of more quantifiable evidence in this area. Yeah, therefore, we propose to use our own data to start looking into this and see if we can at least start to extracting some signals out of those data that previously no one is looking at, and see if we can use that to help the care managers who are using the product to call the patient every day and try to provide them some indicators as of how the patients are being engaged and how likely they are going to be engaged and how likely they are going to be accepting certain intervention. Right. So 4 steps are involved in the analysis. So first, as we said earlier, we are inspired by precision medicine to find the behavioral phenotype in order for us to know that how to group them together with those people who have behavioral similar patterns together. And then we can start then to imagine how we're going to engage them differently. Right. And then once we have this behavior subgroups, then the next thing is then to predict how likely they are going to be engaged on a particular day when the care manager is making a call to a particular person. Right now, they are basically calling their patient alphabetically or randomly because there is just no indication of who should be called first. By knowing who will be engaged more, then it will be a better indicator for them to do task prioritization, to better use their time, and to increase the work productivity. And then the third step is then, as we said earlier, there are people who are responding to different intervention differently. Can we then start comparing the intervention effectiveness for these different individuals and knowing that which individual will be more responsive to what interventions, and use that to guide the selection of personalized care planning. And then finally, how do we adapt this accordingly to what we observe from the patients themselves? Yeah.
So step 3, so this is
Not for electronic record, but for the care management data, right? But we are using the causal inference inspired technique. We can't say we are really using causal because we don't have the marginal structure model to really justify that, but we are trying our best to apply causal inference to estimate the intervention effect. Yeah. Right. So the kind of data we use are collected in the non-for-profit provider network of our client pool. And in particular, we use those records where care managers have called the patient and really asked them to implement some intervention in order to attain their health goals. So using that kind of data, we are able to define whether a person has achieved the goal or not. And because we also know what intervention has been given along the way to that patient, so we can use that to estimate the effectiveness of interventions. And these are from the kind of intervention we are talking about, just to give you a rough sense, are something like more like a referral or versus education versus coordination, which is to follow up with providers on refills, or like screening. We ask the patient to really to watch themselves for some symptoms that they had to watch, versus coaching, which is more sophisticated. They asking them to follow a standard procedure in order to get better to lessen their side effects, or something more like other here is more about effective transition, which is after the patient get discharged from hospital, there's certain procedure we ask them to follow. And using the record, I talk about where we know that when a goal has been assigned to a person and whether a goal has been completed or not, then we can derive this goal attainment records from the goal attainment labels as the indicator of whether a person is behavior responding to the intervention or not. And this is basically just a 1-0 binary flag that we derive. Then we started to describe, extracting more features from our data set to understand patient and care management behavior. So things like which day they are responding to the calls that the care manager is calling, and whether the care management has been how is the workload, how persistent is the care manager in calling the patient, and whether they are really consistently annotating the behaviors of their patient, they are being watched, being taken care, being attended to. And also some other program goal characteristics, such as what kind of program, whether it's a chronic care program, whether it's a wellness management program, this is a transitional care program, what kind of goals, whether it's a short-term, long-term, or what kind of difficulty we're expecting for attaining this goal. And then the question now then, can we use what we say we are inspired by precision medicine to find those behavioral phenotypes in order for us to start grouping those patients in our pool to different groups that will have some meaningful indication of how they obtain their goal? So if we do this in the traditional clustering way, then it's basically using all the feature we described, right, to project the patient's interventions into the feature space, and we start calculating the distance between these different nodes, and then use something like clustering, hierarchical clustering in this case, to start understanding who are likely to be like the others and who should be grouped together, and then use that to start grouping. But that will not help us in this case, because what we want is not just any clustering, right? What we want is the clustering that can help us to learn the subgroups, that can help us to tell apart those people whose goal attainment is different, right? So we don't want that they just basically subgrouping them by age and gender. We want them to be subgrouped by those attributes that actually matter to goal attainment as an outcome that we care. So in order to do that, then we look into the method co-constraint margin maximization, where, as you can see, we're trying to look into the outcome. In this case, if you look at the upper illustration, you see that the red dots and the blue dots are clustered, cannot be really separated in its original feature space. But instead of just doing cluster on the original feature space, we now project them to another feature space where the blue dots here you can imagine as those who have attained their goals versus the red dots versus those who didn't. So we project them first into this other feature space, and then we can start doing clustering on those attributes that matter more to the outcome we care in this domain, which is the goal attainment. And more detail can be found in the paper we published in CIK and LeroyA. And then once we have that, once we are able to project that, then that projection into the new feature space and being able to cluster people into behavioral subgroups that matter to goal attainment, then we can start using the understanding of those behavioral subgroups to train our models to understand how to predict whether a person will be engaged or not on any given day when a care manager is trying to code this person. And in order to evaluate them, then we start to build three kinds of different models. Yes. So this particular part is about engagement scoring, not yet at intervention effectiveness scoring yet. So this is just basically to predict if you code that patient today, will the patient responded? Right. It's a care management. Right. Here it's just to code or not. Right. So no different types of interventions. We haven't started to compare the intervention effectiveness yet. Here we just want to know by knowing the behavioral subtypes, can you really help us to predict engagement better? Can we do that? Right. And then, so then using that, we build the models and we try to build three different models to compare them. Right. So the first type is population-based, which we train one model using all the data that we have, and to see if we can predict if you code that person today, the person will respond, will attain their goal, or will be enrolled into a program or complete this program. Using that, all the data, so it's a one-size-fits-all models. And then using that model, you go to predict for each individual and see if your recommendation for prioritization is correct. Say that if you say this person will be engaged, is this person really going to be engaged or not? Right. And then the second kind of model is what we built using the subgrouping that we learned using the previous constraint projections that we have already developed. So the goal is then to, instead of using all the gray dots to train a model, now you know that there are patients who are green, there are patients who are red. Some people are persuadable, some people are your lost cause, some people need to be engaged in this way, that's the green, and some people need to be engaged in another way, that's black. Now you know there is these behavioral different subgroups matter to goal attainment. Now you use your understanding of those subgroups to train models separately, right? So you train green model, red model, blue models, and black model to predict whether a person will be engaged or not. And then finally, the third kind of model we train is that we say, okay, so now, even though we know the subtype, but there are often cases that are residing at a boundary which may make the interpretation very noisy. Can we just use, say, the prototypical user cases that we think that are most typical, most representative of that behavioral subgroups, and then we train the models using only those representative cases, and then we use the models that train in the prototypical cases of the different behavioral subgroup to predict whether an individual will be engaged or not. Right. So as you can see, as a result, that although that adding subgroup doesn't seem to be adding much value out of just train the models using all the data, the one-size-fits-all approach, but being able to look at those prototypical use cases help us to further improve significantly on the precision of whether our recommendation will be correct, right? And also, even though I want to point out, even though adding the subgroup doesn't seem to be helping significantly, it adds a lot of interpretation values to it, because now you can really explain to the care manager better why this person engaged today. It's because it fits these behavioral patterns we have observed in these behavioral subgroups of people in the past. So that's why we recommend you call this person today. We think this person will respond much better. Then the care manager can have some indication of what should be done on any given day. At least they started to have some indicator of the engagement level of the patient. Right. And then then the second question we ask is then, now we can observe people in different behavioral subgroups matter to the goal attainment. Can we then use our understanding to start compare the interventions in a way that's more systematically done, and can, at the individual level, recommend interventions for that person's, but instead of applying that one-size-for-all approach as before, then as we told you earlier, that the care manager are given a very heavy books of rules, and they just basically follow it, and then give everyone the same treatment if they fall into the category of certain rules. Or can we start giving the care manager more indication that for this particular individual, how responsive this person might be for different interventions, given what we understand from these patients individually, right? And then that's when we started to introduce causal inference techniques into this learning process. And as we know, there are two camps out there, Suzanne can say to this more than me, that, and here we adapt the potential outcome framework here to estimate the difference in counterfactual outcomes. So this is to compare if an individual was given a particular intervention versus if it's not. And if we are able to estimate that intervention effect at an individual level, then this will help us to be able to compare multiple interventions for that person at the point of care for care managers. Right. So there are many methods that has been proposed before, and some public health informaticians have started applying that at a policy level, for example, to compare whether for smoking cessation we should use education versus tax increase versus indoor smoking ban or some other services. Right. And here, we do not just want to do it at a policy level. We want to do it at the individual level, which is making it more difficult, but also interesting. Right. So knowing that we want to do that, we want to compare interventions at a point of care so care manager can choose which one is the person is more likely to respond to. Then we started using the same framework that we had before. We started to subgroup people, and then we use a model that trained. For this time, we are training the model to do one thing, to estimate the individual intervention effect, which is the effects that we estimate if given this person this intervention versus not, then how what's that effect size. And then and then once we have that individual intervention effect estimation, then we can then train another naive-based classifier, which is to help us to learn the threshold whether we should give this recommendation of this particular intervention to that person or not, whether that person will respond or not. Then we know that what's the cutting off threshold there for knowing that when using the estimated individual intervention effect to know that when should we recommend a particular intervention to an individual or not. Then we compare across the different interventions that are available options for that individual at a point of care. And then we use that to select the recommendation for individuals. Then we need to also evaluate this, but it's more difficult to evaluate than the engagement model because, as you know, that we can't observe person twice, one with this intervention, one without. So we had to be more creative here. And so we come up with 3 different levels of evaluation here. Well, the first one is then we are going to give this person the no care planning options of recommendation, which is always recommend the best performing intervention anyway for that individual, given the population level evidence. So if across the board that these interventions is always better, is statistically better in this population, then we always give that particular intervention to that person as a no care planning options. And then the second kinds of recommendation we implement is then we use that individual intervention effect estimation to come up with a population level ranking. And then we always given the different subgroups and knowing the ranking of the intervention, we always give the patients, if that person belongs to a particular subgroup, then we will use that ranking to provide recommendations. And while the third option here is the most individualized we can come out with, which is then to use that individual level effect estimation we have come out with at a subgroup level, and then use that to decide whether which recommendation will be given to an individual. Then, as you can see, the result shows difference in terms of baseline, the no care planning option versus the machine recommendation, but the difference between the population level estimation with causal inference versus the individual level estimation is not significant, right? But here we are at least able to provide some initial evidence that if you have some understanding of the subgroups, then it's important for you to use that understanding of your subgroup to come up with the personalized recommendation, even though it doesn't have to be purely at the individual level, but a subgroup level would be helpful. Right? And then just to iterate that what we have done so far. So we have used the constraints projection approach to help us to project the features of a patient into another feature space to help us to subgroup them as the matter to the outcome we are observing. And then we are using those understanding of the subgroup to help us to measure the engagement level and being able to predict whether a care manager should engage this person today or not. And then we can further incorporate causal inference technique to help us to evaluate at any points of care what intervention might be, the patient might be more responsive to, and use that to guide our selection of care planning. And then finally, that leads us to a more longitudinal precision engagement plan that we haven't been able to do, but we will need to do it with certain types of data, such as mHealth data. Right. And I know that Ken and Ming here probably have already talked about some of the previous work we have done in this area for the stress part. So that's why that today I might not emphasize that on that part, but I just want to take you quickly into the to have a overview of what we might be able to do there if we can further add the mHealth data into this domain. So say that we have a virtual assistant that can be assisting care managers at home. So instead of having the care manager calling the patient, now you have a chatbot at home, maybe your Alexa, maybe your Google Home, that can answer the questions and also guide you to answer some questions in order to understand better which factors that are driving the difference in terms of your response to certain interventions, right? So say medication adherence, we know that there are so many 20 more different factors that can hinder one person's medication adherence behaviors. So which factors is the actual barrier for that particular person? Do you know which questions you need to ask the patients? Given so many different instruments psychology has developed, which question is the one that you need to ask the patient today? That's the very difficult question even to humans, right? So how do we then guide the machine being able to select for so many different instruments in order to narrow down to the particular barriers for that person's medication adherence hindrance, then use that to guide our selection of follow-up interventions? That's the questions that we need to ask. And if we're able to do that, then we are able to further, as we said earlier, to triage people into different intervention groups. Some of them might need to have intervention right away. That barrier is something that we can do something about to remove them if we following certain action plans. Or it can be that there is no action needed, right? So there are different ways to triage the intervention space if you are able to have that interactive arms with the patient a little bit more, right? And then incorporate it back to the care manager product. Then we can use that to guide the care management to engage and discover and decide better at any points of time. And then finally to drive the improvement, right? Yeah, and then as I only have 10 minutes left, I don't want to go into full details of this, as I said that earlier, that Ken and Ming probably already talked most of it about it. But I just want to quickly lead you to some of the thinking that we have previously done in this area, which is to use the Q-learning to help us to learn how to then select the right pathway for individual to going forward. And in particular, instead of guiding them using the one-size-fits-all guideline again, like in the sports medicine, they recommend walking 9,000 steps a day, as always. Here, now, if we know our end goal is to reduce someone's stress level, we can actually use the observation histories of what we have of the patients and their walking step and their incremental reward, which is stress reduction, in order to help us to learn a little bit about that human psychology that are previously hidden, that without being able to systematically spell out. And in particular, this can be used to guide better coaching. So now, if you are able to know a little bit more about the sub-goals you need to set for an individual in order to lead to the optimal stress reduction in the end, then you know better how to engage them, how to advise them at the different stages of in their ways of implementing their own fitness plan, right? So the previous work in these areas is really trying to then decouple the one very big goal into several stages and being able to learn then at each stage what would be the right threshold for us to set a value for certain action, so we know how to guide them better at each stage. And then we implement this using the 180 days data collected in the behavioral cardiovascular health centers in Columbia University. And in there that they have been asking people not just for their stress level, but also have their environmental exposure and have some of this step data coming from the mobile devices as well. Right. And then they ask them 3 times a day that how stressful they are. Right. And previously finding is that if you just train one model using all the population data, it cannot outperform the model that you train at each individual. Right. So this is really a point where we say that other than the nomostatic model, we really need to have an individualized model trained using the N01 data. And then using the method that we mentioned earlier, which is to trying to decompose a big goal into a sub-goals using this multi-stage threshold Q-learning methods implemented, then we are able to advise to see that if a person follow this kind of multi-stage learning, then whether the person will get more stress reduced or not. And the result shows that if they do follow through those multi-stage recommendations, although in the smaller pools of patients that we can observe that the stress reduction is definitely 7.4 times more than the baseline. Right. And then using this, then the next step is then previously this kind of pathway are being implemented just on the data that have the step counts on a daily basis, right, without being able to look more into the intraday level of changes, right? So can we couple the better with another more precision stress measurement, like say that's available in the commercially available watches, and then do that in a way that can help us to really start understanding how to intervene on intraday basis, right? And then we then started to implement in these wearable watches that can help us to use consumer-grade sensors to monitor more reliably on the signals of acute stress. And then we are trying to then deploy this in the field to people who are doing their daily life activities and see if those commercially available watches with consumer-grade sensors can be used to detect stressful events in the field while they are out there doing their own thing. right? And I don't have the time to go through this, but I just want to say that the results is that if you look at the typical workday activities, our models and our sensors, our model trained on the commercially available watches with consumer-grade sensors were able to detect the stressful events that I think we have earlier published this in AMIA 2017 with 78% of accuracy of detection. Right, and then now, really, I want to end with this slide to say that medicine is really a science of uncertainty and art of probability. Only when we started to noticing the individual variability among individuals, then we can start to really work out the science part instead of just an art. Right, so, and all what we are doing right now is trying to help us to identify that individuality and how do we better describe them, interpret them, and make it actionable and back to the clinical flows by using the care manager and later with the mobile devices. Okay. So, yeah, if you are interested, then there are papers that we have published. Yeah, many of these with Canon. Mm-hmm. And yeah, so we yes, so the model was pre-trained in the lab, right? So I didn't go through the whole process, but we did a lab study first with the arithmetic test, so to induce stress, and then we use that to understand the relationship between load sensor measurement and the stress events, right? And then we implement that models in the field, and then using that to detect whether a person has gone through any stressful event as they in their daily activity reports. So yeah. So on the watch there is also the interface where they can specify what activity they are going through. Right, yes. So here, yeah, actually the person was randomly pinged. So it's not just because they're stressed, so we ping them. It's also that there are some randomization components in this, so they don't know whether they are pinged because the machine detects the stressful events or not. They are basically just being pinged almost all the time, but they have to provide the activities log throughout the day, so we can start learning what are those events that reported as stressful and whether our physiological response that we detected in the consumer-grade sensors can be used to detect those self-reported stressful events. No. Right now it's just sensors. So it's heart rate variability and also the step. So only these two kinds of sensors. So those are so if you see red, then those are the self-reported stressful events. Right. So the blue one are those that are not so stressful, and the yellow one is in the middle. And our evaluation earlier is trying to detect those red ones. And that's what I say earlier, that we have accuracy about 78%. So just by looking into the sensor data, the model's trend, the model trained with those sensor data, we are able to detect those red events here. So meaning that if in the future you want to implement this, you no longer need to poke them to ask them whether they are stressful or not anymore, right? So you can have some confidence that just by looking at the physiological response, you know whether this person is stressful or not. And that can help you to have some clinical meaning here, because then you know better when to intervene for a particular patient, as we know that this is very individualized response. Some people are more physiologically susceptible to certain type of stressors, while the others might be more responsive to other stressors. So this really had to be done at the individual level. That's why it's important to have the device coupled instead of just using EMA. And as we know, the recall-based survey is also not reliable. So if this can be implemented correctly, reliably, then this has a lot of implication to what can be done in the daily life to provide more precise clinical insights to the individuals. Right. Yeah. Right. Yeah. Right. So that's why we want to work with people in the field to start implement the zero field, so we know better the relationship to interventions. Right. So right now we can tell you a person is physiologically responding to some stressors, but we don't know how to intervene yet. Because there is no intervention in this part of the study, as you have noticed. Right. So the next step will certainly be given doing the trial, to given different intervention to individuals and see how they respond differently and have a way to quantify that. Yeah. So so we are trying to do this certainly with some clinicians, but if anyone interested, we will certainly be interested in talking to you more, right? So one case study we are recently starting is opiate addiction. So say that for people who are addicted to opiate, there are different interventions that can be given to that person. How do you know when and what type to give to that person is really the key, right? And how did you incorporate more contextual information other than just sensor data to provide that meaningful, interpretable, actionable insights for clinicians so they can choose which intervention to be given to the individuals. It's the key. And a lot of method has already been implemented in the field, but we really need to bring this into our larger scale studies to give us enough data to prove the point. Right. Yeah. But that's the important step, but that's not the whole story. Right? So to make it really actionable, you have to be tied to some certain interventions. And that's the hard part. How did you get enough data to really learn that well? As there can be many different types. And as we know, people respond to intervention differently. How did you know which type of people responding to which type of intervention, and whether there is any contextual factors that playing an effect here when deciding on which type of interventions. Yeah. So, and to be able to use AI machine learning, we need a lot of data, which is often the hinder factors here. That's why we really need to work with people in the field to do this. Yeah, okay, sorry, I'm over time. So I will just stop here and we can talk more later. Thank you. Thank you.